Wonderful. Thank you for being here. Thank you for showing up. That's Rance's quote. My name is Bastian Hauck. I'm the CEO and the founder of dedoc, the diabetes online community. dedoc is a community by and for people with diabetes. And one of the most important things we have been building over the last couple of years is the dedoc Voices program. It is today the largest scholarship program in the world. We bring diabetes advocates from now over 80 countries, and we have some 300, 350 alumni already, to some of the most prestigious conferences in the world. That is ISPAD, it is also EASD, it is ATTD, it is ADA in the US, Diabetes UK in England. Of course, the German Diabetes Association's conference, we are based in Berlin, in Germany. We will be at ATTD Asia in Singapore in 5 weeks and hope to come to India and the Middle East and more in 2025. We do this because we believe in the value that people with lived experience, people with diabetes, bring to these kind of conferences, and I believe that many of you will have already heard, seen, and engaged with some of our crew. And I think you will have seen some of them and heard some of them ask questions that are maybe slightly different from the usual kind of questions being discussed at scientific and medical conferences. We believe this is important. I will stop at this, and because instead of talking too much, as Renzo always accuses me of, I think we will rather let our dedoc Voices and our actions talk. We have a fully packed program for the next hour and a half. I will not go through all of them right now. We will introduce them in just a moment when we kick off. These are the amazing dedoc Voices and speakers we will have for the next hour and a half. Before doing that, I would like to introduce the other dedoc Voices who are also here. We have brought 25 dedoc Voices from all over the world, from I think 17 countries this year to Lisbon. And we have another 25 dedoc Voices as virtual participants who are currently joining us remotely. This symposium is being live streamed, so I'm also, I don't know which camera I'm supposed to look at, saying hello to everybody who is following virtually from around the world right now. We usually have several hundred people following. You can also ask questions during the symposium. Please do so by using the comment function on the Facebook Live. And we will be tracking whatever is happening on Facebook Live. And if there is a question and we have time, we will loop it into this real discussion. So thank you and welcome to everybody following, regardless of where you are, regardless of whether it's in the afternoon or early morning or in the middle of the night right now. The same goes for you throughout this symposium. Please, if there's questions, if there's comments, hold them. We will have an extensive question and answer session after the presentation. Now, the dedoc Voices that are here, please all get up for 1 second, turn around so that everybody knows who you are, the wonderful people joining from around the world. Thank you. Please take the opportunity to meet these amazing folks throughout what is left of ISPAD, meaning now after the symposium, maybe tomorrow or tonight at the recognition event, should you be there. One last thing. Oh, if you want to comment on anything, please also observe our socials so others can connect and contribute and see what you're thinking. One last word, a program like this, bringing up to 200 people from around the world to 10 different conferences around the world would not be possible without financial support. dedoc is supported by some amazing corporate actors. I know there's differing views about receiving financial support from pharma and medtech companies. If you are in advocacy, we couldn't do what we do without the support of some amazing companies who have been standing behind us and at our side for the last years. For the year 2025 and for the dedoc Voices program, these are Medtronic, Lilly, Vertex, Dexcom, and Sanofi. Thank you very much for making this possible. Without further ado, I would now like to hand over to David and Karolina, who will give their words of welcome from the ISPAD perspective. David, thank you for hosting us.
Thank you very much. Thank you, Bastian. And I don't know if Karolina Beaufort is here, but she is very fond of saying at the dedoc sessions that ISPAD was the first conference that had a dedoc session. So we're proud of that. We're proud of the collaboration that we've had the last many years. Also, we have patient advocates now, a membership. I think we're about 30, so consider joining. It's not that expensive. And also, we have now a member of the advisory board is always going to be a patient advocate. And so welcome, 50th anniversary conference. It's not just a conference for ISPAD, but we work during the year. And join ISPAD, be active, help us, help educate us, inform us, be part of ISPAD. And with that, I will introduce Karolina, who is on the advisory, and she will give her perspective. So thank you.
So good afternoon. Hello, my name is Karolina. It's very nice to see you all here. Thank you for invitation. And this is a very special moment for me, I must admit, because it's my 10th ISPAD anniversary. I started as a volunteer in ISPAD. I was always an active patient advocate in my foundation in Poland, also internationally. And I want to thank all healthcare professionals who were supporting us and gave us this voice, this possibility to somehow help us, to listen to us, so we can together bring our perspectives and make the diabetes world better. Of course, as David said, I also encourage you to join ISPAD because we are starting. I have this huge honor to be the first patient advocate on ISPAD advisory board. We are going to start some new projects, also with Tino, who is here. So hopefully you will join us and help us improve it. And not to prolong it, I want to invite you all for wonderful lectures because we have wonderful dedoc voices here who will share the stories of what they do because all of them do amazing things. You should totally follow them up on Instagram and see their amazing stories. And as they say, nothing about us without us. So enjoy the lectures and let's learn one from another and make the diabetes world better. Thank you.
Karolina and David, thank you for not only extending the words of welcome, thank you for hosting all of us. Thank you also for keeping it short and brief because we really want to give the voice to these people. However, we are very aware that this is not just some ISPAD conference, it is not just one of the many you have done. You are celebrating 50 years of ISPAD. And to honor that, it came a bit of a coincidence, but to honor that, we have invited our dedoc artist in residence. It is a program we started in 2020 that was then kind of disrupted by the pandemic. We brought it back to life just a couple of weeks ago, and I am proud to introduce Taylor Appleton Lawrence, our dedoc artist in residence from New York City. Taylor, come up, because Taylor has created a specific piece of work to honor 50 years of ISPAD in Lisbon. We have briefed him with some of the background information, and he brought 2 originals and an amazing limited poster edition, which, by the way, if you're interested, and you will find these cards on your seats, you can buy a poster, limited to 50, or bid on the originals. But Taylor, you will have to say something yourself.
Thank you, guys. Thank you, everybody. It's so nice to be here, to see some new familiar faces, some new and old friends. I am Taylor Lawrence. I'm a street artist and artist doing work for diabetes awareness from whatever city I go to. Like many of you, I'm a type 1 diabetic. I was diagnosed at 6 years old. And when I say diagnosed, I mean I went into a DKA coma and languished with sugars into the thousands for days. I'm about children, I'm about preventative medicine, early detection, and just the awareness that sometimes we all feel very alone in this. Sometimes you're very alone, and sometimes you're most certainly not alone with a group of friends here. I was inspired by the 50th anniversary, which is just an incredible accomplishment. It's also remarkable that our disease is centuries old, but it seems like a sci-fi movie that we're living in sometimes. You will can see on the originals downstairs that you passed, I included the Lisbon flag in the background of the images you will see downstairs in the original. And what else can I say? I'm just very happy to be here with all new, lovely friends, and glad to be part of dedoc and just an awareness program. Thank you, guys.
Thank you, Taylor. We love you. And I think doing advocacy through art is something we should think about more often, because what we have learned over the last couple of days is that just having this poster and having his two original pieces at our dedoc booth, it triggers the most interesting conversations that go into very different directions from what we're used to at scientific conferences, and we love that. Having said that, let's kick off with the dedoc symposium. Our symposia, since they started in late 2019, early 20, have always carried the same title, What We Wish You Knew and Why, where we is us, people with lived experience, with living with diabetes day by day, and you is you, the usual attendants of conferences like these, the HCPs, the nurses, the researchers, the representatives of pharma, medtech, etc. And we just like to share some of our stories, experiences, positions. We do this quite a bit online. We do this on World Diabetes Day every year. We do this through our acclaimed Doc Days, which are virtual events that happen multiple times throughout the year. And whenever a conference like ISPAD gives us the opportunity, we do it live with a couple of dedoc voices on stage. And David, you are right. ISPAD was the very first conference to officially host us at their conference. You're also the first ones, again, the trailblazers, setting up what Karolina was just talking about, and you were mentioning setting up your own advisory board. We think that is amazing. Others, like the largest conference in the world, EASD, are following suit. They have been inviting us. They have also tasked us with doing something similar for them. dedoc will be running a similar advisory council for EASD for all of their conferences and guidelines in the future, which is great for them, I hope, but also great for us, and definitely great for people living with diabetes and HCPs and nurses around the world. With that, and without further ado, I would like to hand over to Ines. Ines is one of our dedoc voices. She has been, amongst many other things, running an EU-funded project called Diabetes and Sports, DIAPS, and she will talk about education and how using the resources they created supports peer support, and how she's been using that, and especially how that program is continuing. Ines, kick it off. Thank you.
Hello to everyone. So as you know, my name is Ines. I'm a former athlete. I'm living with diabetes for almost 20 years. And I have been in sport. I was an athlete for almost 20 years also, but in the last 5 years I'm working as a sports supporter, especially in the topic of sports and diabetes. This is a Super D. The Super D is an athlete living with diabetes. Super D is a kid living with diabetes and tackling their own normal physical activities during the day. Super D is a child to some parents who want to be their best for their child. Super D is an athlete to the coaches who want to make the child to perform as better as possible. I would like to ask you all of questions like, how many people do you know that they stopped training or doing any kind of sport when they were diagnosed, when they were afraid to jump in the sport? This is a question, but I know a lot of people who were brave enough to continue doing sport, but their coach didn't want to do it. So their coach said, I don't want to, I don't know, and I don't want to be responsible for you. This is a project that came from that background. This is a project that was patient-based and based on the topic of multi-sport associations that wanted to tackle this problem. The whole idea of the project started like almost 10 years ago, so 2016, when we gathered that problem and when I started doing European projects, and we got the idea to make something like this. It will never ended up to being such a big deal because we were thinking like, we want to just educate our coaches in our community, but we ended up to being educating all around Europe and all around the world. This is after 3 years of the project that was co-funded by the European Union. It is a project of the handbook and the comic book for the children to be based and that everybody can understand it. In our consortium, we are calling it Sports and Diabetes for Dummies because it's so easily written that everybody can understand it, because the most important thing is that diabetes is individual. Why we had so much success with this project is something that our medical expert, Professor Felice Strollo, said. This is a project that ended up putting on the same table doctors in medicine, nutritionists, psychologists, but also sport scientists, kinesiologists, coaches, but also but also athletes with diabetes, kids, and their parents. They all had their role in this project, and they all had to the same focus to make this as accessible as possible and understandable as possible. After these 3 years of that project, we ended up in having different things, because we all know that there is, I think, more than 100 sports in the world. So, and not all of the sport is the same. Every sport needs a different training, and with that, it needs different management of diabetes. It's not the same if you're training football, or you are skiing, or swimming, or just water polo. In that way, we realized that kids, mostly kids, they don't need so much education. Most of what they need is a peer support. Is a support where they can find somebody on the other side of the world, find out somebody who is doing the same sport, having the same issues, and tackling different things. They all have different tips and tricks that they can share, and making a community for this topic. So our next phase after that was developing a digital platform where everyone can join, every athlete with diabetes, every kid, parent, but also coaches and experts can join the platform, can ask the questions, can find somebody who is similar to them and who wants to share their story. Ask questions. We know that there are no stupid questions, but sometimes you need to know that you are getting the right answers. And this is the topic that we want to prevent. So, to wrap up everything, you can join our website, sportsanddiabetes.eu. You can see how you can participate in the sport, but also about the book, you can download it for free. It is available on 5 languages for now, and we are going further to translate it to even more languages, that everybody can just print it, hand it to their coach, and say like, yes, you do want to train me. Thank you.
Thank you, Ines. That was wonderful. Hi, everybody. My name is Renza Shibilia. I am here. I wear many hats, but right here and right now, I am wearing the hat of dedoc, Head of Advocacy. And I'm so thrilled to be here, as I always am, because we are showcasing the stories of people living with diabetes and the amazing work that they're doing. And I am so delighted that I am now going to introduce Jyotsana. And the reason that I'm delighted is because now you are going to hear her story and about the incredible work that she's doing. One of the real strengths of this of diabetes advocates and the dedoc voices is collaborative efforts. And Jyotsana is going to talk about the work she's doing training usher workers in India. This is so incredible. Have a listen. And make sure that you do have some questions for later in the session, because you'll want to know more, I promise. Thanks, Jyotsana.
Thank you. Thank you, everyone. My name is Jyotsana Rangeen. I'm from India, and I'm a person living with type 1 diabetes. I also am a diabetes advocate, and I run an organization called Diabetes India Youth in Action in India. And so today we're going to talk about the role of community health workers in strengthening care. So to start off with, I'm going to talk about the situation of type 1 diabetes in India. And when you see out the numbers, currently we have 1 million people who live with type 1 diabetes, and nearly 900,000 people that should have been alive today, but we have lost them. And the reason is, the most common reason is lack of access, lack of education, and lack of timely diagnosis of children at the right age. And when you look at these numbers, it is mind-boggling. And the reason why I thought of doing this project, I actually was thinking about a project. I was already involved in a lot of different initiatives. And I was a young leader in diabetes program with IDF. And when I actually researched about these things, I thought I really have to do something to educate people about type 1 diabetes at scale. And luckily, my aunt served as an Anganwadi worker for 35 years. And I had the chance to visit one of the centers where she worked and meet with Anganwadi workers, learned about the work they do and the kind of challenges they face and the kind of impact they've created. So when I researched about these community health workers in India, I got to know the pivotal role they have played in polio eradication, in Clean India movement, and so many amazing initiatives where they have played such a big role. And then if we look at India as a whole, we have total 1.4 billion population. And I mean, when you look at this number, interestingly, we have 22 official languages and 20,000 local dialects. And I mean, when you look at that, it's huge. I mean, it's good way in one way that we are so diverse. We have different languages and cultures, but it also brings so many barriers, language barriers, cultural barriers. And when we look at the rural population, 65% of population in India is living in rural areas. And I thought, like, this is something that we need to do. Like, whatever we are doing is not enough. We really need to go at the grassroots level and teach people at the rural resource settings who are losing lives because of undiagnosed and misdiagnosis of type 1 diabetes. So every child in rural area is not getting the access and standardized care that they deserve. And it's really sad to know that we have come across so many cases where we weren't able to save a child because of undiagnosis. And the solution to that was the project that I started back in 2020, was working with these community health workers. So I'll talk a little bit about Anganwadi workers, ASHA workers in India. So they are actually part of the Integrated Child Development Services in India, which is run by government. And they offer services to mothers and children in rural areas, providing with them nutrition, education, and health services. So they are bridging a healthcare gap and reducing the divide between urban and poor healthcare system. And they're actually the go-to person for everyone in the village because they also reduce the cultural and linguistic language barriers. So people are more comfortable going to them for any challenges or needs. So I thought they would be the best and the perfect positioned people and the strongest network for us to educate about type 1 diabetes at scale, to ensure that we have timely diagnosis, the right treatment, and standardized care given to everyone and everywhere, to every child in need. So this is the kind of model that we are following currently. We have localized T1D education to ensure that all the Anganwadi workers know about the early signs and symptoms of type 1 diabetes. They are able to also advocate about insulin usage. Because of these language barriers, a lot of people living in rural areas resort to Ayurvedic cures, and they easily fall prey to these free treatments for type 1 diabetes and false claims. So it's very important that we have these strong allies and network of women who are teaching them about adherence to treatment and having like a proper follow-up care. We are also having like educational materials and structured training programs for them so that they can provide better care and treatment and management for type 1 diabetes in India for children. We are also having door-to-door campaigns so that the education reaches every household in rural area. It shouldn't be just restricted to urban people, but every household, every family in rural area need to know about type 1 diabetes and what they can do so that the child doesn't land into decay or any complications or doesn't die without a diagnosis. Also, community health meetings is another aspect that we will be introducing so that there is proper follow-up care and also a referral in place so that these Anganwadi workers can connect these people to the healthcare providers, because a lot of people in rural area have this taboo of not going to doctors, not taking insulin, not checking their blood sugar. So it's very important to have that proper, robust mechanism where there is follow-up care, continuous monitoring, and management of type 1 diabetes. And as I believe that when you educate a woman, you educate a generation. And through this project, which I call Ignited, I believe that we are empowering these grassroots champion leaders to amplify their influence so that type 1 diabetes and awareness and education reaches everyone, everywhere. And we don't face a situation where we lose another child to type 1 diabetes. And this is a wonderful opportunity. So this year, I had the opportunity to participate and be a panel of the first ever in India national type 1 conclave by the National Health Mission. And we had the opportunity to not just have the government, but healthcare professionals, media, people living with type 1 diabetes, organizations working for type 1 diabetes, all coming under one roof, talking about how we can strengthen access to care for type 1 diabetes. And I think it was a wonderful movement that was started by Chai Foundation and Breakthrough T1D in India. And I'm really honored. I was part of it. I was able to share about the work, about the projects that we do, and also we emphasized on the importance of educating these Anganwadi workers. And the big win was that right after a few months of that first conference we attended, we got to know that the Madhya Pradesh, the state where we did this conference, they actually included type 1 diabetes screening as a mandate as part of the RBSK program under the government of India for screening below 18 years of age by Anganwadi workers in school, and also provision of glucometers and test strips for the facilitation of these screenings. So this is like a huge win that happens with just one meeting of everyone coming together, and this is something that we need to manifest, that it happens in every state. And that's the goal that we are working towards. So here are some key takeaways just to end, that with 1.4 billion Anganwadi community health workers, and the special part is they're all women-led. So these are strong, amazing champions who are part of the community, and they're serving the community, and they're helping us bridge the gap in healthcare in India and reduce the disparities, especially in low-resource settings. And I'm happy that if we can use that strong network, make them strong allies, and really educate people at scale about type 1 diabetes. Thank you so much.
Thank you very much for that amazing presentation. I'm sure there's questions here in the audience. We're getting quite a few on the live stream. We will get to those later. If you have questions, please hold them, write them down. We will have time for questions and answers after the other speakers. Our next speaker, I am glad to introduce Mo, my good friend and dedoc voice. Mo is originally from Gaza. He currently lives in England. And he will be talking also about education in a way, but primarily about how to prepare for crisis situations that are very real where he is originally from, but more in the general context. Mo, thank you for joining us.
Well, absolutely, and thank you so much for having me, and thanks to ISPAD, of course, for giving us the opportunity to be here today. Yes, my name is Mohammed Seyam, and just to mention, I am a healthcare professional myself, so a lot of the views that I'm sharing today could be, again, same as Renza, multiple hats all the time. A healthcare professional and a person with lived experience. And I'm happy to share a perspective that I believe is definitely crucial in managing and caring for diabetes in humanitarian settings, which is our perspective as people with lived experiences. And what we wish healthcare professionals and policymakers would know about us and about our needs, and what exactly is the role of community-based advocacy to shape better policies and responses during crises. To start with, I do not have any slides, sorry. To start with, in the last few decades, the number of humanitarian crises and emergencies around the world are increasing dramatically. And according to UN OCHA, nearly 300 million people in 72 countries around the world require humanitarian assistance. That's the most recent statistic by UN OCHA. And definitely the high and rising burden of non-communicable diseases, including diabetes, of course, is reflected among crisis-affected populations. And in addition to the direct consequences of emergencies on people with diabetes, and those emergencies could range and varies from armed conflicts, natural disasters, prolonged displacement as well. People living with diabetes are profoundly affected, and they are especially vulnerable in such situations as their health can quickly worsen and decline. And the existing guidance on to support implementers, including governments, international organizations, humanitarian implementers, healthcare professionals themselves, researchers, and of course community-based organizations and advocacy and advocates themselves, is limited in designing effective models and effective models and approaches to deal with diabetes care in humanitarian settings. Definitely people's access to essential diabetes care, supplies and medications is likely to be limited in humanitarian settings. That's most likely due to insecurity, instability, displacement, collapsed healthcare systems, interrupted supply chains, and that's definitely important for insulin, cold supply chains, the change of health behaviors and lifestyles for people living with diabetes and such settings as well. And unfortunately, in humanitarian settings, what's really important is the sidelining of NCDs and diabetes care in those settings, because the focus is always on acute trauma care and communicable diseases. And that's why whenever we want to talk about people with diabetes in humanitarian settings, we mention them as the silent victims of crises. But advocacy always rises, and the global diabetes community always stands up to support people with diabetes who are in need. And I'm going to share a little bit about what we've done in the past year in Gaza and what we're currently doing in Lebanon to be proactive in the current escalation in Lebanon. So since the onset of the crisis in Gaza, all of us in the international diabetes community have joined to seek a way to support people with diabetes and their needs. And the approach that we have followed is, or varied from a top-bottom approach and a bottom-to-top approach. So we were like kind of moving diagonally here, directly supporting the community and engaging with the community through educational sessions, peer support sessions, online groups, support groups, connecting people directly with educators, with health professionals, with community mobilizers, and connecting them with health facilities and connecting them with the professionals on the ground who can potentially support them. And while doing so, we were gathering a lot of information about their needs, because that is definitely important as a facilitator for the work that could potentially be done. And when it comes to the top to bottom approach here, what we gather from the needs of the people living with diabetes could potentially help, did help us a lot in talking in roundtables with implementers on the ground, with humanitarian organizations, to initiate or align the efforts to support the coordination that has been done among international organizations. We've helped them a lot to standardize the care that is being provided for people with diabetes in the settings, because we've noticed that sometimes a lot of organizations would deal with patients based on their own guidelines, and that would potentially result in mistrust from the community itself. Despite the challenges that we faced regarding access to diabetes supplies, specifically insulin, giving the complexity of the context itself, we were able to support a lot of medical missions with that's all solely by the diabetes community so far, by diabetes supplies, by insulin. So we can again support, even if it's limited, support people with diabetes. Now, what we're doing in Lebanon is trying to be proactive with a lot of international bodies to include diabetes care and to integrate diabetes care into health system responses in Lebanon. And MSF are currently leading in this by engaging people with diabetes to standardize the care guidelines that they're providing, engage them in the mobile clinics that they have, in the WhatsApp groups that they create for their own patients. So we're trying to be proactive, but again, crises are always unpredictable. Crises are always, and no country, of course, is immune to crises. So here are the keynotes that I wanted to leave you with in regards to this. The first one is diabetes care cannot be an afterthought during emergencies. And given, of course, the multi-faceted burden and the complexity of diabetes care and the challenges around diabetes care itself, it is important that we think of complex solutions sometimes that involve all stakeholders, of course, involving people with diabetes themselves. Those solutions must be innovative, must be collaborative, because collaboration is the first and key role of actually doing something at the higher level of coordination for a crisis. And when it comes to solution, the most effective and the most efficient solutions for people with diabetes are the ones that are co-created by people with diabetes, by the people whom are affected directly, because they know their needs, because they know what's lacking for them, and it would give and serve to ensure, of course, the continuity of diabetes care in emergencies. It's also crucial that the whole health community does not wait for the onset of crises to react. It's important to be proactive for crises. No country is immune to emergencies, and proactive approaches help us to shape better and more resilient responses. Three, which is really important, and it's a big challenge that we have faced in the past couple of years, is trying to bridge the gap between all stakeholders, including researchers themselves, to be able to implement frameworks and to be able to enhance the work that is being implemented by international bodies. We need evidence. And evidence is lacking in humanitarian settings, specifically, again, with the sidelining and marginalization of NCDs, including diabetes. So bridging the gap between all stakeholders, including researchers and people with diabetes, is important. The community itself, of course, is an important asset to coordinate with. It's an important asset to understand and tailor the responses based on their needs. And we need to ensure that people living with diabetes have a voice and are meaningfully engaged in decisions around their care. And lastly, of course, for healthcare professionals themselves, the path forward, I think, is clear. It is about engaging with the community, listening to the stories and to the needs, and working with the community to develop health systems that hopefully do not just survive a crisis, but also thrive through crises as well. Thank you.
Thank you, Mo. That was fabulous. We talk about hats a lot, don't we? Wearing different hats. The other hat that I wear is I work for Breakthrough T1D, and in particular in the Global Responsibility team. And one of the groups that we work with, and we're so grateful to work with, is the Sonia Nebeta Foundation. So there's worlds colliding here with dedoc, Breakthrough T1D, and the Sonia Nebeta Foundation. And Nathan is going to speak about his experiences there. I'm so very, very excited to hear this talk about the last mile and the work that he's doing. Thank you so much, Nathan.
Thank you so much, Renza and Bastian, for the opportunity to be part of this symposium. I'm honored. My name is Nathan Rubangakene from Uganda, a T1D. Yeah, my presentation is going to be on the last mile. I'm a project coordinator with SNF, Project Mishra. When I say last mile, the most remote location where access to transport, electricity, basic need is virtually non-existent. That is what, when we say last mile, that should what come in our mind. In the middle of that, I will be talking of a warrior, of a warrior, of a warrior. Warrior is a term in Africa where when we say a warrior is a person with type 1 diabetes who lives with great courage, strength, perseverance, resilience, and optimism. In fact, is an inspiration to all when I say a warrior. Maybe briefly about me. A child from the last mile, born in an abject poverty in a remote area of Alero, Gulu. At the age of 7, I lost my father, and at 12, I also lost my mom. My younger brother and I were left in the care of my grandmother. Diagnosed with diabetes at 17, remember from that time of losing your parents, and at 17 I was already diabetic. And this was a heavy blow. We did not have all the money for food, leave alone essential supply and insulin. There was no, food was also a challenge. A missionary met me and enrolled me in school in Gulu. It was this school that I met SNF that provided me, relieved me from the burden of medical supply. After the high school, SNF supported me through my diploma in pharmacy. I now run Project Mishra with SNF, yeah. Maybe briefly about Project Mishra with SNF. They provide educational scholarship and critical support to warriors who face the greatest vulnerability, warriors on this last mile. I run this project. With over 120 warriors under my care, I travel over 1,500 kilometers each quarter to conduct on visit, follow up on education and crisis with these warriors, and see their general well-being in the area where they live. On this presentation, on last mile, we are going to be, survival is going to be our primary focus at the last mile, where we are going to be talking about problem with access to healthcare facility. We are going to be talking about poverty and food insecurity in Africa. We are going to be talking about awareness, stigma, and social stressors. And then lastly, we are going to be talking about literacy and T1D education. Meet warrior, a warrior who lives in Aleptong, Obim, Uganda. Mother is a peasant farmer. Father were about unknown. Nobody knows about the father. Diagnosed at 6, travel 3 hours to the nearest health facility. The facility where these warriors goes to serve 150 warriors in the T1D clinic. The clinic is staffed with a nurse and a warrior coordinator. The nearest pediatric endocrinology, one of the 4 we have in the country, is 170 kilometers away from where this warrior lives. Meet another warrior on our second point in poverty. Meet a warrior, lives in a Toyota village, Maahs, Uganda, third born of 5 siblings. diagnosed at 5 years old. Parents are both peasant farmer, earning less than $5 a day. On average, 3 nights are mealless night. These people don't have food like in a week if you're to put an average. The home does not have electricity, refrigerator for insulin storage. Now on our point on awareness, stigma, and psychosocial stressors, 72% of warriors in Uganda feel like they are a financial burden to the family and caregiver. 33% of warriors are afraid of being excluded from activities at home because of T1D. 68% of warriors are afraid of their friends and family in the community where they live finding out that they have type 1 diabetes. People think it is contagious. You can spread diabetes. 34% are afraid of being excluded from activities at school or thrown out of school because of their diagnosis with T1D. This is still a big loss in our. Now on illiteracy and T1D education. In Uganda, SNF camp data has shown that in northern Uganda, where I live, I come from, I serve these warriors, 98% of warriors have difficulties understanding a glucometer reading. They don't understand and complying with T1D regimen. Similarly, 81% of warriors need help from their caregiver to understand and manage their diabetes. Numerously, literacy and cognitive skills are a must for good outcome. T1D education and community are essential in the T1D management. The future would like to see this. Access to insulin syringes and essential supply. To us warriors, insulin is life. That is what one language that we all unite in, insulin. Different technology, but what we all looked at is insulin. Maybe if it's spoken in another language, is insulin. Yeah, so insulin is life to us, the T1D. Sustainability of essential supply is perennial source of stress for warriors and their caregiver. So continuity of supply supplemented with delivery mechanism is essential. The government and broader NGO community are important. Improve healthcare infrastructures. Health workers are not as knowledgeable as they could be about T1D. There is need to train them so they could transfer correct information about T1D to warriors. And it is so unfortunately that in Africa, people think diabetes is the same. Type 1, type 2, nobody knows how to differentiate them. So a lot of wrong information is being passed to the children, which are not right. People are struggling with bad information in the community. Education is a big part of T1D management. Program like SNF Project Border Border can be scaled up to improve access issues. Focus on social determinant of health. Poverty is endemic and exacerbate challenge with T1D. How can you inject when you have no food? How can you try and find transport to the hospital when your earning is less than $1 a day? Is a hard thing, is just stress. Optimal T1D outcome require cap counting and adjustable insulin dose. But how when you can't read or count? This is a big stress. Stigma in the community put warriors at risk. This is another stress. School discriminate against warriors is another stress. the future is a world of warriors by warriors. Without the T1D community, I would be nothing. T1D is hard, and even harder in the developing country where we all come from. Context, you need support from communities that understand the condition. Building a thriving community with warriors with lived experience at the heart of T1D care model at SNF. Our ultimate goal is a world of warriors by warriors themselves. I want to end my presentation by saying, together we can with all this. Thank you so much.
Amazing. Thank you so much, Nathan. So we're going to do a Q&A, but first we have a couple of, there we go, a couple of little things to continue and talk about. Firstly, oh, we love a bit of a launch, don't we? Today we are launching, that isn't a typo by the way, a new resource called Language MattHERs. It is a new resource that joins the incredible catalogue of language matters, information resources and position statements around the world. And this one is for women with diabetes, by women with diabetes. It was led by the Diabetes Foundation and Jazz Sethi, who isn't in this room, so you can't pat her on the back because she is in, I think, Hall 3, or no, we're in Hall 3, Hall 2, giving a talk about this resource. So please do go and have a look at it. It's absolutely terrific, and it's really focusing on the work about improving communication with, by and for women living with diabetes. And it's been a very, very long day for some of us because this morning at 8 a.m. we launched the update to the T1D index, which I hope all of you know about. We saw some of the data spoken about earlier today. Today we had a new launch, a new brilliant interactive dashboard that gives you an opportunity to have a real deep dive into the data. So if you go to t1dindex.org, you will be able to have a play with that new dashboard and have a look at it. So that's where we are with a couple of things that we want to talk about. Now we're going to do a Q&A. I'm going to go back over there and sit down. My blood sugar is a little bit low, so if I keep standing up, I might topple over, and that's not going to be fun for anyone, especially me, because then I've got to get up. All right.
As we're already doing the announcements, we were planning to do this at the end, but we'll do it now. Just a couple of save the dates for DDoc. I think we got the order confused, but it doesn't matter. Save the dates for DDoc. We are doing a call for application for the DDoc Voices Scholarship Program. One is open right now for ATD Asia. This is specifically for advocates in the Southeast Asian context. If you are interested or know of someone who would be a good fit for this community, please let us know, talk to us right now, or scan this QR code. It'll take you straight to the application form. The next call for applications is going to open on November 1st and end of November for Diabetes UK. That is specifically for advocates in the United Kingdom. And then for ATGD 2025 in Amsterdam, we will open the call for applications also on November 1st. Before that, way before that, in just a couple of weeks, we have World Diabetes Day, and we run the virtual World Diabetes Day. We have been running it for the last 5 years for the whole country of Germany under the patronage of the German Ministry of Health, and this year under the patronage of Peter Schwarz, the IDF Global President. We also run it as a global edition together with IDF Global and IDF Europe. These are both virtual events. They're about 90 minutes to 2 hours. They're similar to symposia like here, although presentations are usually a lot shorter, so we can fit a lot more from all over the world into these 2 hours. If you're interested and have time, join us on World Diabetes Day. With that, I am sure you have questions. We have received comments and questions from all over the world on the live chat. We have had comments and questions from Mexico and Kuwait, from the Philippines and Bangkok, from LA and Saudi Arabia, from Pakistan, India, the Netherlands. I'm not going to go through all of the countries, but a lot. We will, however, prioritize. I apologize to those following from around the world. Thank you for following. Thank you for sending your questions. We will prioritize questions here in the room first, and Renza is going to moderate that. And if there is time, then we will read some of yours. We'll see how far we get. We have about a good half hour left. Thank you first of all, for being here. You were amazing. It always amazes me, the stories we can bring together. And these are just 4 out of 25 here, out of 600 around the world. Thank you. Renza, kick off the presentation.
Please do come to the microphone to ask questions so that everybody can hear. This really is a great opportunity for you to learn more about what we've already heard about, but also to ask questions more generally, I guess, about community engagement and the work that people with diabetes are doing in their communities. Which is going to lead me to the first question, actually. What we have seen here is some remarkable instances of collaboration. And that seems to be a theme, really, at ISPAD. I've heard this throughout the whole conference, the power of collaboration. So you're holding, Ines, you're holding, I guess, the microphone there. But what is it that you would say to people, whether they're other people with diabetes in the room or clinicians, about how to approach each other for collaborative projects? If you've got an idea, you've got this brilliant idea, how did it get off the ground? What are the sorts of conversations that people can have to make something like this a reality? How does it start early on, if you like?
So for me?
No. Can we have the mic on? Do we need to do anything? Yep,
On
now.
one? Yeah.
Go.
Okay.
Yes.
So for me, it was that I was already in the European project, so I already knew how to get the grants for the sport projects. And in our way, we were trying to find the grants from the sport part of the European Union. So we didn't approach to the healthcare, to the pharmacy or anybody. We were trying to go it on the other side to get the funds from the other way. And in all of that, we were approaching to other clubs, the other multi-sport clubs, that we asked them few questions about the trainings, kids with diabetes, do they have maybe a list or something? And it ended up that some of their coaches did actually ask that question, where they can find or something like that. So, and it ended up to being a huge topic, which we were thinking that we will have the interest of only 1 or 2 multi-sport clubs around the Europe. We ended up with 10. We needed to make the list down because we couldn't have that many partners. So in my case, it was quite easy question because something like this didn't exist.
Fantastic, thank you. Have you got anything to add to that, Nathan, I guess, about how to have conversations, working with community even? What are the sorts of things that people need to hear to feel confident with the work that you're doing?
Thank you, Renza. I will bring it in the context of Africa.
Please do, yeah.
Yeah, maybe to ask the Africans, I can say the voices. Every time we get the opportunity to speak, maybe that is where we can start from. Yes, thank you.
Thank you, fantastic.
Same question?
Yeah, the same question. And I guess, because, as you said, you wear many hats. So does that make it easier? Do you think you can...
It does actually, yes. Sometimes it would be, it would be hard to, because again, in the context of humanitarian settings, it would be hard to deal with the community itself, given the burden that they're living. In multiple times before, and we investigated that multiple times in the earthquake in Morocco, in Turkey as well. People want to feel secure to be able to give back. And if they're afraid for their life, if they don't have the supplies, if they don't have a system that supports them among healthcare professionals, then that's definitely a challenge and an obstacle ahead of advocacy that we needed to solve. So yes, it is in humanitarian settings, it is hard to involve the community if insecurity and instability is a problem. But again, people feel for each other, and that's, I think, something that makes the diabetes community very special, that we're a very united community. There is always something that links you as a diabetic with another diabetic around the world, because your needs are all the same. So it's easy for us to connect advocates from all around the world. The challenge is not with healthcare professionals. It's that healthcare professionals, sometimes in humanitarian settings, we don't have guidance so healthcare professionals can act upon. And that's one of the biggest challenges that we're facing. And the solution actually starts with risk reduction, because for emergencies, you don't, what you get in an emergency and responding in an emergency is what you prepare for. So integrating NCD care into humanitarian responses, into emergency responses, integrating NCDs and diabetes in primary health settings, community engagement at early on is definitely the key there. In recent decades, we're making progress towards doing that, with integrating NCDs and diabetes in such context, but a lot of effort is needed. The gap is still wide, and it definitely needs bridging, and it needs further community engagement to ensure that the needs are met.
Fantastic. Thank you. And Jyotsana, perhaps if we could also expand on that to talk about, I know that we are working together with a number of, on a number of different projects, but you mentioned the T1 Champions Day, which brought together clinicians, and it brought together the incredible inpatient network out of India. And how important is that collaboration, of that really strong connection between clinician groups like that and a network of remarkable diabetes advocates as well?
Yeah, I think it's very important, because when you share the same passion, like it's coming together and sharing the success stories and making them believe that, the work we are doing, it has an impact and it has like a goal that we all need to reach together. And these kind of collaborations help us to not just amplify the voices, amplify the work we are doing, but also do knowledge sharing, get to know about the different things and approaches that we can take, how we can connect with government, how we can connect with other organizations, and really like just expand the work that we're doing and scale it up to the next level. So like I was just talking about the Type 1 conclave that happened with the NHM. So the only thing that really moved them when we shared our own personal stories, when we shared about our work, our lived experiences, that's something that really moved and helped them to understand the real challenges faced by people who actually live with diabetes. And I think that was the reason why it was so easily adapted, and we have so many clinicians and healthcare providers who are happy to support. And also, I would like to say Breakthrough T1D has been amazing and like very supportive to us to really help us scale up this project and reach the goal that we have all in mind. So I think the collaboration is the key, and knowledge sharing, and ensuring that the impact and passion reaches every person that we reach.
That's wonderful to hear, and I did see the two Breakthrough T1D people in the front cheer there, so thank you. Yes, Bastian.
I can at this moment maybe say something. I had the slide up in the very beginning with the logos of the corporate partners supporting the dedoc Voices program. What I didn't say is we are also being supported very, very generously by Breakthrough T1D since this year for the very first time. We are very, very grateful, especially as this support is earmarked to bring more diabetes advocates to the dedoc Voices program, specifically from the African continent and from India. This is great. The only reason we didn't have the logo on there is that with an organization like that, you always have to ask for clearance before you can put the logo onto anything, so it comes with a bit more of bureaucracy. But thank you very much to everyone involved at Breakthrough T1D to supporting the dedoc Voices program, which also makes it possible to bring people like Nathan, like Jyotsana, and many, many more to ISPAD.
Wonderful. Thank you. Yeah, thank you. Please do come up to the microphone. I'd say we've got a really quiet group, but half of the people in this room are dedoc Voices, and you are not quiet. Kara, thank you. What would you like to ask?
I don't want to ask something. I just want to say something to Nathan and to you. I'm really thankful for your story and to bring it up to this platform. Just to remind us, we are talking about hybrid closed-loop systems and a lot of technology, and I feel like I punched in my stomach, because if I see your work and your incredible advocacy work, I feel so humble, and I thank you so much for whatever you do in your country, and to bring it up here to remind us of how privileged we are, and so to make us see how much work is left to be done to get rid of these disparities.
Thank you.
Thank you so much.
Thank you,
Yeah.
David.
And I think that, that's one of the things about dedoc is that we want to hear as many stories and as many experiences as possible. It's why we put out a call for scholarships every year. We don't keep going back to the same people. We keep saying, please, we want new voices. We want to hear these stories. Everybody who is living with diabetes, your story is valid, your story is legitimate. Your advocacy efforts should be shouted from the rooftops. And this is our rooftops in some ways. So, we're so thrilled that we get to hear these stories. Tino, who I refer to as the hardest working advocate in diabetes. Go.
Okay, thank you. Like I've always been saying this thing, now that I'm working closely with some of our healthcare professionals, and one thing that usually disturbs me is that it's not a question, I'm just saying for one point that you were saying, to say that we know most of our healthcare professionals, this knowledge that they still use is maybe what they got when they got trained to be healthcare professionals. So really, they don't know anything about, they're not really involved in research. If they want to come to a conference like this, which I would have loved them to be here, they would have to pay from out of their pocket, and usually they're underpaid, and also they're overworked. So it would be a huge strength for them even to be able to come to a conference like this. Of course, I get to be in a conference like this, I learn so much, but I cannot be telling doctors what to do, how to do it. It only helps me and maybe some of my community members, but I cannot give medical advice. But maybe if there could be like a way in which Breakthrough T1D can help, or Life with Child, or whatever, PECTWA, and so many other initiatives in which we can have at least 2 or 3 healthcare professionals from low to medium income countries so that they can also come together. So if we are to create standards, we at least know that, yes, there are people like this is what they're doing, and these are their standards of care, and in a way, trying to capacitate them, because really they would have loved to be here, but they cannot do that. So I think that was just a point that I thought I could employ, and if there are funders or corporates who would love to do this, we would love for you to support our healthcare professionals so that they tell us good things when we see them in clinic. Thank you.
Terrific. Thanks, Tino. Great suggestion. Apurva.
Thank you. First of all, before I ask my question, I just want to say kudos to you guys for having that courage to come here and share the work you all are doing. Everybody has some ideas, but you guys made it happen, and all this shows your resilience of standing here and proving what people and all the naysayers have said, you cannot do this, but you've done it. So kudos to you guys, and thank you for sharing. Now that we were talking about bureaucracy, politics, all of that, and we are in this room thanks to so much that is happening, I want to have this conversation around the power dynamics around in global health systems, right? It took years of advocacy. And I'm sure a lot of people, you all four, would relate to that all of this advocacy sometimes has been voluntary, right? Like you all have done because you're passionate. You are doing it out of your work stuff. And a lot of you must have felt not valued, but you've still kept going, right? So how can we, as advocates, formalize this whole WHO conversation, talking from a global health perspective right now, formalize the expertise of patients and make sure that as we are at the rooftops here, how can we raise the bar of our rooftops at a global health level, at ministerial level, that your expertise is actually an expertise and not just on the sidelines as a checklist of tokenism of advocacy. I want you to just share what do you want and what does your ministers and all those people who are sitting at these policy makers should know. We deserve a better rooftop now. We have to be accountable. And I want to hear from you. Where do you think we can change that narrative and how?
Oh, that is such a great question. So let's talk about this. This is about recognition. It's about recognition of expertise, of experience, and recognition in the way of being reimbursed for that expertise and experience, right? Yep. Okay, Jyotsana.
I would just like to, thank you for the question. It's wonderful. And I would say that, I had a quote which I forgot to mention during my presentation. It is by Sir Ratan Tata. Unfortunately, we lost him a few days back. And he said that do the right thing even if it is not the easiest thing to do. And I believe that, in my own advocacy journey, I've faced a lot of ups and downs. It hasn't been an easier journey. Also, when I started with this Anganwadi project, it was like the peak COVID time, and my family was horrified that what's wrong with this girl? Why is she spending time with community workers in our village, wearing double mask and gloves? But what I saw, the impact that I saw when I actually started getting calls by these workers telling me that please come and teach us, telling me that they found a child that is showing symptoms, I think that I was doing the right thing and I'm on the right path. And as you said, that it's very important that as an advocate, you should be recognized, not just on different platforms, but as someone who's doing some really core work, just like these community health workers who are being funded or being supported by Indian government. So like, even if you're not doing it full time, but you're still putting in a lot of time and effort, and you are going through all of those challenges. So definitely they need to be recognized either by the ministry or the governments in every country, or by organizations who are working for the diabetes. So I believe in that.
That's a, yeah, please keep going.
I would love to, but do I have a conflict of interest because I'm a healthcare professional myself?
You can fight with yourself if you want right now.
Everybody has
I'm not going to fight with
does the
myself. No,
Pulver.
no, but what I want to say, I remember during the peak time of me trying to advocate, our friend Bruno here has said an important message to us. It was here in Lisbon, actually. It was here in this venue 2 years ago, and he said, advocacy takes time. And it's never easy. We always say that it takes a village. We always say that it's we need to keep fighting for it. You need to, and we have a lot of initiatives, and now as voices talking in conferences about it. But I feel the more we keep talking, the more opportunities we'd be getting. A lot of the work that because I don't want to fight with myself, but a lot of the work that I'm getting at the moment is not directly related because I'm a healthcare professional, but because I'm an advocate who understands the context. And it's work by international bodies that are currently working in crisis and trying to understand the problems that the patients are having at the moment. What are the needs of the patients? And answering those questions are not necessarily directed to healthcare professionals. It is directed to people with diabetes who can connect and contact people with diabetes and connect with them on a human level, which is extremely important. So yes, it takes time, it takes a village. We need to, again, we've been talking a lot about collaboration among all stakeholders, but also it is really important for us to keep collaborating in the community, supporting each other, helping each other with every opportunity possible to be able to continue and move forward in this career.
Thank you.
Yeah, and I think, Nathan, I have a question for you here, because one of the things that you mentioned was that you've been working with the Sonia Nebeta Foundation, and the foundation actually supported your education to do your pharmacy diploma. Was that a way of recognising the work that you had done up until that point?
Please, if you can come again, sorry.
Yeah, no, of course. So you'd been working with the Sonia Nebeta Foundation, and the foundation supported your education, your pharmacy diploma. Yes. And I was just wondering, how did that come about? And do you see that as a way of supporting what you had already been doing with the foundation?
Yeah.
Yeah.
I could say it's like paying back.
Yes.
What I have, maybe the little they had, they do for me, and then right now I move all this distance and trying to stand in the gap where they cannot reach all of them. Yeah.
Yep.
That is what I can say.
Yeah. And I think that's a really interesting way. You know, we talk about recognition, and we talk about how we can support advocates who are doing amazing things, warriors doing amazing things. There are creative, different ways, perhaps we need to think outside the box for ways that we can do that. Yeah. Yes.
Can I add one more thing?
Of course you can.
Thank you. Sometimes the reimbursement that you're getting is mental reimbursement or psychological reimbursement, because you get paid back by, for example, finding a purpose in life because of diabetes, because of the advocacy that you're doing. People spend their lifetimes trying to find their purposes, and in order to be able to find your purpose at an early stage of your career because of diabetes, because of the people that you connect with through diabetes, is definitely a way of recognition, a way for yourself to feel proud about it. So that's definitely a way of recognition.
And we definitely cannot close this question.
I love that.
We
I
can't.
adore her.
We can't close this question without thanking dedoc for having all of us here, all the voices. I think this is one way of recognizing us and making sure that we are able to share about our work, because not everyone gets an opportunity to be part of this prestigious conference and share about the work. So thank you so much for that.
Thank you. I
You're
will
very
not
welcome.
take more time, but I'll just say kudos to you guys for doing this, because it takes years. The HIV movement started by people living with AIDS, HIV, and you are one of those first people who've brought people with lived experience on platforms like these. And I think this is one of the pathways to make it recognized. So thank you.
And to respond to your question about how do we get to the other rooftops, dedoc actually has a seat on the WHO Global Compact Board, so we are involved in that, and we are trying to get as much feedback as possible from our 300-some alumni, and that goes into everything we add whenever we add something there.
And many of
But-
our alumni are involved in the WHO Compact
Yes.
as well. It's a very circular sort of thing. The DDoC voices keep popping up because they're being given these opportunities to do that, which is really important.
And to your, Jyotsana, I actually don't like the pay it back and thank you things. The motto by which dedoc runs is pay it forward. I never really want to hear somebody say thank you, dedoc. I would much rather have this person take that feeling of thankfulness or gratefulness, take it home, turn around, and then do something on the ground. And this is what we're seeing here. So thank you guys.
But manners are excellent, so thank you for being so polite. Okay,
We have
thank you. We've got more questions.
Questions
Sana.
here and 6 more online.
Yes, so responses, keep them nice and tight. People asking questions, ask a question. No sermons, go.
Okay. I'm overwhelmed by your stories, so thank you so much for sharing those. I kept hearing one very common theme amongst all these stories, specifically in yours, Ines, yours, Nathan, yours, Mohammed, to some extent in yours, Jyotsana, but yes, peer support and community-led work. What are your hopes for this peer support and community-led initiatives in the global healthcare space? How do you see that being accepted, formalized? I think it relates back to some of the questions that Apurva also asked. How do you see peer support being more acceptable, formalized, integrated into the global healthcare space? And do you think that that's something that needs to be done or not?
It definitely needs to be done. It is definitely being done at the moment. Peer support is one of the pillars of community engagement, and that's a framework that is already developed by the WHO. So work is being done at the moment. But yeah, again, it takes a village.
Here also?
There is. Ines, do you want to add to that? Because I'm really curious to know how that has worked with your work. Is everybody good? Everyone's low. Everyone is low right now. We're throwing things at each other. Ines.
So in my way was more of a finding that peer support, so recognizing what do other needs and how to make that. So in my way, what I found like 20 years ago when I was an athlete, when I was struggling with how to manage diabetes, and today I had the discussion with Santiago, and I told him, like, I was training for 20 years, and I have never had, like, the perfect way of how to reach good blood sugars during the trainings. It's not because I wasn't giving all. I was always, like, having the failures, but I was always keep going and try to do something else. But in my way was that I couldn't find anybody who was training the same sport, who was having something, and I was just like, at that time, I was really, really trying to find somebody. And in my way was just like a recognition that something is missing, and having just a few leaders who are willing to do something. But I don't know, did I answer the question or something? But it's I think more of a, like, it ended up on the advocate to do something, just to recognize what is missing and try to improve that.
Thanks, Ines. Okay, thank you, Sana. Let's ask the next question, please. Hello. Please introduce yourself.
Thank you. Suzanne Sapp. I'm a pediatric endocrinologist from Cameroon. I got the answer to my question, how to motivate our young leaders to engage themselves. I have the question. But now the question they ask me to, why are you not present on WhatsApp, which is the most spread social media in Africa, if they want to engage?
That's a really good question. So this is about going to where people are, right? So if it's WhatsApp, then that's what people should be using. If it's, you know, whatever it might be. So who is you? I think perhaps let's ask the question of, you know, how do you find out exactly, you know, what are the best ways to communicate with people and reach people? And is that what you're doing? Has that been part of what you've done, is to work out what it is to reach the most people? Did I get that right? Yeah? Okay, great.
I can try to, like, from my way of that we have done, like, through whole of the year that the project is running up, we were trying to explore what is the best way of building the community and trying to reach out to the things. And actually WhatsApp was one of the, like, questions, like, why don't we use something that is already existing and build that to the people. In other ways, like after some like surveys that we have done and everything else, we did find out that, for example, WhatsApp is not something like that we need to do something else. So it's just like a research was besides that to see what will be the best opinion in what would other people do.
I think simply it starts with mapping what would be the best option, to like asking those people with diabetes what is the best way to reach out to them. In Lebanon at the moment, for example, to be proactive, what MSF is doing is they have a WhatsApp group. Sometimes people do not reply to WhatsApp groups, so they don't have the time to reply to WhatsApp groups. So what they're doing is sending voice note on those WhatsApp groups to ease communication with health professionals and give advice. So it's about the context and mapping what would be, again, the best for the community. So again, research, we need answers for the community.
And we're going to move on because we've got more questions, but I just want to say this is the whole thing about, I will not hear people say that people with diabetes are hard to reach groups, you know, they won't engage. It's not about that usually, it's about not finding the exact methods in which people respond best. And so I think that's a great point, Mo, is about, you know, working out, asking the question, engaging with and co-designing solutions, whatever they may be, for whatever it is, to make sure that you're going to where the people are. Okay, hi. How are you?
Yeah, just a quick question, really. And firstly, absolutely essential work that you're all doing diversely, not just around the world, but diversity in diabetes care, and that's the unique part of it. So my question really is to ISPAD and other conference organisers, whoever's in the room who has an influence there, and that is maybe linking into what you're just sharing, is we need to get heard. We're out there. And so maybe ISPAD 2025, next year, you guys are the opening ceremony kind of panel, so that kicks off the conference, you know, number one. I just think can that be possible for ISPAD to get the lived experience to the front?
So unfortunately David did need to rush off, but but yes, he will send in the stream, and Karolina can feed this back, and what a great idea though, love it. Hi.
Hi, I'm from the founder of an NGO in Mauritius. I'm also the father of a 21-year-old diabetic since 20 years. I can relate to the stories that you've spoken just before, because I've been trying to help where I've been able to do. And having that opportunity to be here today, and it's just my comment, is really great for me, because 2 months back, I was not going to come here, and I sold my car, and I got one of my colleagues, and we got here to fly to hear all these conversations, make all these contacts that would not have been possible online at all. And really, it is great to be able to just attend and have all these conversations. I've been working all day all day long. I'm completely dead after the sessions, but it's so much pleasure to, and wish you all the best in your future, and
Thank you
everyone
so much.
else.
Thank you.
Thank you.
All right, we've got a couple of online questions, so let's
Yes.
see in our last 5 minutes if we can perhaps jump
And
to
David
them.
Maahs, who just came back in, the president
missed
of
her.
ISPAD. You missed the most important comment of the day.
Does Gavin want to say it
But-
again? No, Gavin, jump up again. Gav, where are you? Here, go on, ask it again in a...
We'll bring it up with Fergus Cameron, who's the president. He'll be the president starting after tomorrow, and then and the local organizers, Julie Van Oppen and Melanie Henderson. Yeah.
Thank you. Okay, Bastian,
So,
take it away.
We have very little time left, but there were some very concrete questions to some of the presentations here from all over the world. Let's see. There's 2 questions specifically to you, Jyotsana. One is coming from Pakistan. The question is, Jyotsana, as a neighbor of India, we can very well resonate with the challenges involved in screening, especially in rural areas. Screening does not mean screening like, screening for stages. I think screening, what is being referred to here, is the very basic screening for the signs of type 1. Are there any certain percentages that you can share that you come across amongst people with T1D, and are there any specific demographic factors? Comparing India, Pakistan, do you have numbers? Do you have?
I don't have the numbers now between India and Pakistan, but I came across a study about the percentage of people in India, especially one tertiary hospital in Delhi, and the mortality rate was 11.6% in 1 year. So that was an alarming figure to know that the follow-up care, the misdiagnosis, the late diagnosis is one of the commonest reason why we're losing children to diabetes. So that figure was alarming, and it takes guts to release such a paper, but I think it could be much, much more than that. But yeah, I would really like to work on those. Yes.
And you mentioned the number of 900-something thousand people that should still be alive. This is the narrative, the main narrative behind the T1D index. How many people should be alive if care was better? That is also, it struck me, I don't know if you heard a presentation at the first day of ISPAD here about Laos, and that until 15 years ago, that's not long ago, it was assumed that there were no adult type 1s in that country. That was actually a correct assumption, because there were no adult type 1s because they were dead. There's another question for you, Jyotsana. How frequent do you need to train your ASHA workers, and in how detailed is that training, and is it also in these many languages and dialects that you mentioned?
Yes. So I'm currently doing it in Delhi. So I'm doing it in the Hindi local language for the community health workers. And we do monthly sessions. And also I'm trying to build a WhatsApp network of these Anganwadi workers so that we can provide some local educational materials so that they can use them for their door-to-door campaigns. And also we kind of build a network or an app or a website where they can upload the data about the common community health meetings that they would be doing, and as well as the data they would be collecting from the door-to-door campaigns, and as well as any challenges or support they would need through this WhatsApp network. So these sessions would be on a monthly basis, and we're also creating a structured training program that would really cover the early signs and symptoms, how they can help a child, what will be the referral program, and it will cover an extensive, proper structured program, training program that would cover all of these things.
Last question.
Last question goes to Ines and Nathan. The question is coming from Africa. I don't know, it didn't specify the country. It says, thank you, Ines, for the project regarding sports. I am wondering, is there a way that this could be adopted for type 1 warriors in Africa? And what have been the lessons learned? Maybe that goes too far, but could this be adopted? And that question is to you and also to Nathan. Would that be something that could be adopted from your perspective? Programs that have been proven sufficient and working in Europe, could these be adopted? How would you feel about that?
So about the full handbook, I think that it's mostly, it can be adaptable to anywhere in the world, because we were trying to be like very not strict with the measurements that you need to have, because we don't know in which way you are feeling the best to start trainings and everything. We did share some of the proven measures from the researchers, what are the best ways, but like it's different ways in different countries and everything. So we have done all of the research in English, and this is the best language, but if it's translated, and it's easily to reach. And the other thing that I can just say that we got some comments about our Super D guy, that it's really like, it's blue. Nobody in the world is blue, so it's like it can be like translated, and it can be everywhere in the world, because it's a blue, so it's like it doesn't have any culture or a general background to it, so that can help maybe also.
Please, if I can,
Yeah.
if you can.
Sure. So
can I try to explain it? Maybe the question, so
Sure.
that I get and I answer the real thing we are in.
So the question is, a book like this that's already being used around the world, and about different issues to do with diabetes. In this case, it's to do with exercise. Do you think that this is something that perhaps could be used with your warriors? Could the information that's in here be something that would be relevant, perhaps, and could be passed on? So if you have a young warrior who wants to know about diabetes and exercise, you don't need to start from the beginning. You've got information that you can already use.
Okay. Thank you.
That's okay.
Yeah, maybe just to summarize, maybe to say it in a way that I can.
Yes.
Griffin came out with a dance. It's one of the dance you do, showing injection site, and maybe something that is not in the book, something that kids like to do the real actions.
Yep.
Yeah, maybe something like that.
So something relevant.
Yeah, something relevant.
Love it.
Yeah.
One sentence literally to that is just making sure that this definitely diabetes in sport is important, but you need there's a context specific again. In different countries around Africa, in the Middle East, for example, what's available, what's not available, what can you do outside, what can't you do outside?
Yeah.
You need indoor. It needs to be context specific. But again, it's an amazing project. So
love that.
Definitely.
Great. Okay, Bastian, you have like 30 seconds.
We're at time, we're over time. So thank you everybody for being here. Thank you for joining. Thank you for staying. Thank you to the many people that were watching online. Sorry we didn't get to all the online questions. We tried to do our best, but 90 minutes passed so quickly. Thank you again to ISPAD, to David, to Tino, to Karolina, to the many people involved on the ISPAD side for having us. And thank you primarily to our wonderful dedoc voices for having the courage, as it was said, to come up here, talk, share your stories. This was wonderful. This was dedoc, the dedoc symposium at ISPAD. Have a wonderful rest of the conference. Bye-bye.